today's urine analysis practical part 2, you will learn the microscopic examination of urine for cells, casts and crystals and how to interpret a urine full report. First, let us learn how to prepare a urine specimen for microscopic examination. Take 10 to 15 ml of fresh urine to a conical tube and centrifuge at a relative centrifugal force of 400 for 5 minutes to produce a sediment. Sample has been taken from the centrifuge and you can appreciate there's a sediment being formed. Now a pipette is used to transfer the sediment to a glass slide. Around 20 microliters of sediment is covered by a glass cover slip. And examined initially under low power, and then for further identification of the elements, the settings are changed to high power. Blood present in urine as intact red blood cells is called hematuria, and these red blood cells appear smooth, non-nucleated biconcave discs measuring approximately 7 micrometers in diameter. Some of the major causes for hematuria include renal calculi, glomerular diseases, tumors, trauma, pyelonephritis and anticoagulant therapy. Red blood cells that vary in size, having cellular protrusions or are fragmented, are termed dysmorphic and have been associated primarily with glomerular bleeding. Another type of cell seen under the microscope is the pus cells or the white blood cells. White blood cells are larger than red blood cells and measure about 12 micrometers in diameter. They contain granules and multilobed nuclei. Increase in urinary WBCs is called pyuria and indicates the presence of an infection or inflammation in the genitourinary system. Urine crystals are formed by the precipitation of urine solutes, including inorganic salts, organic compounds and medications. Crystals can be routinely classified as normal and abnormal. Triple phosphate crystals are seen in alkaline urine and can be easily identified by their colorless prism shape that resembles a coffin lid. Ammonium biurate crystals are yellow-brown in color and are seen in acidic urine. They have a thorny apple appearance, and these are seen in all specimens and may be associated with the presence of ammonia produced by urea splitting bacteria. Uric acid crystals are seen in a variety of shapes including rhombic, four-sided flat plates, wedges and rosettes. They appear yellow-brown and but may be colorless. Increased amounts of uric acid crystals are seen in patients with leukemia receiving chemotherapy and Lichtenhein syndrome. Calcium oxalate can be recognized as colorless octahedral envelope or as two pyramids joined at their bases. Cystine crystals, they are colorless hexagonal plates seen in cystinuria, which is an inherited metabolic disorder that prevents reabsorption of cystine by renal tubules. Tyrosine is seen as fine colorless to yellow needle-shaped clumps or rosettes. Is encountered in inherited disorders of amino acid metabolism. Leucine crystals, they appear yellow-brown spheres which can be concentric and radial and having radial striations in the center. These are seen in liver disorders in which amino acid metabolism is impaired. Cholesterol crystals, they are rectangular plates with a notch in one or more corners, seen in disorders of lipiduria such as nephrotic syndrome. Another component seen under the microscope in urine are cas. Cas are the only elements found in the urinary sediment that are unique to the kidney. They are formed within the lumens of the distal convoluted tubules and collecting ducts. There are several types of cas. We have the cellular cas, the red cells, the white cells and the epithelial cells, and hyaline cas. So, you can see that the red blood cell cas, they appear orange red color, and the cas matrix contains red blood cells, which is seen in glomerulonephritis. And now you can see the white cell cas. The cas matrix contains white blood cells, which are seen in pyelonephritis and acute interstitial nephritis. Epithelial cell cas are composed of renal tubular epithelial cells attached to a protein matrix. These are seen in renal tubular damage. Hyaline cas are colorless and has a homogeneous matrix, and these are seen in a number of conditions like glomerulonephritis, pyelonephritis, chronic renal disease, congestive heart failure. They may be found in healthy persons after strenuous muscular effort. Now, let us interpret a urine full report. This patient is 65-year-old male. So, you can see that the urine protein, there is 3 plus, which indicates there is a moderate amount of proteins being excreted, and the centrifuge sediment is normal, and the urine sugar, ketones and bile are not detected. So, this patient is having a proteinuria which needs to be investigated. This is another urine full report of a patient of a 43-year-old lady. You can see that the color is normal and the appearance is turbid. So, turbidity can be due to pathological and non-pathological causes. Pathological causes include red blood cells, white blood cells, organisms like bacteria, yeast, lipids, and non-pathological causes include mucus, squamous epithelial cells, semen and fecal contamination. So, the rest of the parameters you can see the urine protein, sugar, ketone bodies and bilirubin are not detected. On microscopy, pus cells are present and it is significant. If more than 10 pus cells per high fiber field is detected in females, it is significant. There are few epithelial cells present. So, a few epithelial cells can be found in urine as a result of normal sloughing of all cells, and these organisms are also detected. So, these findings suggest that the patient may be having an urinary tract infection. So, that is the end of the urine analysis practical part 2.